Thank you for allowing me to speak with you today about the association between nutritional risk and the incidence of surgical site infection. We'll be going over some of the issues that really pop up in everyday operating, and hopefully this will lend some useful technique and tips to your practice. My name is Casey Thomas. I'm a trauma critical care surgeon. I've been doing that since 2005, mostly at academic level 1 trauma centers. These are my disclosures. For learning objectives today, we want to examine the evidence on the role of poor nutrition status as a risk for surgical site infection, develop strategies and identify patients that are at risk for nutritional problems, and employ interventions to prevent complications, both surgical site infections and identify the nutritional risk among surgical patients, both pre-op and post-op. So we'll be covering, to reach those objectives, we'll be covering these things today. We always think of nutrition as an in-hospital thing, but really we have to look at the pre-hospital, the intraoperative, the post-operative, and the rehabilitative phase. All that encompasses the nutritional status of a surgical patient. We're going to go over blood sugar control and how important that is in getting good outcomes, smoking cessation, patient hygiene, weight loss, and there are many other factors. With one lecture, we can't cover all of this, but these are kind of the top factors along with nutrition that lead to surgical site issues. So in the preoperative phase, I love this, this little cartoon here. You know, we do a great job at doing a bad job. And I'm just as guilty of this as anyone else, but nutrition, so many of our patients have poor nutritional health coming into our office, and it really needs to be evaluated before we book any surgeries. A lot of our patients have debilities, and we're essentially asking them to run a marathon or do a giant workout when they're not ready, and they do not have the nutritional stores or health in order to get good outcomes. Obviously, other factors in that: blood sugar control, getting them to stop smoking, using adjuncts like negative pressure on wounds, patient hygiene, weight loss, MRSA clearance. You know, those are all things that lead to better outcomes as well. But let's start with nutrition. This is a massive, massive contributor to patient outcomes. There are literally thousands of studies, and every indicator that we want to look at is worse with patients that are malnourished. So infection rate, length of stay in the hospital, readmission, surgical outcomes, going to rehab rather than going home. I mean, the list goes on and on and on. And so looking at this in the preoperative phase through short questionnaires is very important. And there's a bunch of ways to do this. But one of the things that, like I said, we're bad at looking at this. This is one of the publications that I think really draws attention to this. This is a summary points consensus recommendation from the North American Surgical Nutrition Summit. There's obviously some very, very big players in there, but their statement essentially: the existence of malnutrition preoperatively or the deterioration of nutrition status through the perioperative period is a well-recognized factor that increase both post-operative complications and hospital length of stay. But unlike protocols that provide perioperative antibiotics, skin preps, intraoperative warming, prophylaxis, thromboembolic disease, little attention is paid to standard nutritional management. And I hate reading off slides, but I think it's important to digest this, that, you know, we really focus on all these other things, all the guidelines that we have in place to meet the metrics and SCIP and CMS and all this, but nobody really looks at how we handle nutrition. And the colorectal surgeons have done a great job with their ERAS protocols and things like that to look for this. But in general, we are not really addressing this, I think, to the degree that we should. And really, nearly 50% of patients that are admitted to the hospital are malnourished or at risk for malnutrition. And so we have to really look at this. About half our patients are at risk for these issues, and they're very correctable. In this study here by Gillis, surgical patients that, again, have a significantly worse outcome, including as much as a 4-fold increase in mortality, greater odds of complications, more frequent readmissions, prolonged hospitalizations, and increased healthcare costs. So, you know, it took me a while in my practice, you know, probably for the first 10 years, I wasn't really looking into this. And then when my elective practice focus really went to abdominal wall and some complicated cases of patients that were very high risk for complication, I started addressing these things with some really pretty easy preoperative screening. And the way we screen for that is really just a dietary history. Certainly patients can be obese with very poor nutrition. They can be on a very high sugar or carb diet with very little protein stores. But we have to use some sort of validated screen, whether that's the Malnutrition Universal Screening Tool, whether that's the Nutritional Risk Index, whatever you want to use in your office. We should be using something to screen these patients to see if there are any issues. And most of these are fairly short and don't take much time in the preoperative phase to look for. But essentially, we want to diagnose these patients that we know we're going to put them in a catabolic state with surgery. The demand is really going to outweigh the stores that they have. And so finding those patients that may be on the threshold and they're not officially malnourished, but have the risk is also important, because we're going to be asking them to undergo a lot of catabolic stress. And so in that perioperative screen, we really want to find those patients that have metabolic abnormalities, either because of their disease or something else. So, Crohn's patients, short gut patients, fistula patients, cancer patients, people that are having some sort of metabolic abnormality associated with the disease that's going to lead to malnutrition. This is where we want to identify them so that we can preemptively load them, as well as post-operatively make sure we're addressing those needs. People with gastrointestinal abnormalities, like I said, short gut, high output fistulas, malabsorption type problems. People have had chronic strictures with intermittent obstructions, things like that. Also, people who have drug-related issues that are leading to their malnutrition, and socioeconomic. I remember hearing a story when I was in the South about from a dentist about Mountain Dew mouth, which I'd never heard of, but apparently it's a situation where people put Mountain Dew in babies' bottles rather than formula or milk, and it essentially rots their teeth as they're coming in. And so it's an issue that you see, and it's an education and a socioeconomic issue that leads to a certain pathophysiology. So these are things that we really need to look at in the preoperative phase. So, whatever tool you want to use, we mentioned a bunch in the past. This NRS 2002 tool has probably the most evidence around it, and it has been validated the most. But in essence, it's kind of looking at it through the lens of having a suspicion that a lot of people are underdiagnosed for this, and then utilizing the same process over and over and over to help diagnose this. No one tool is perfect. Some are more specific, some are more sensitive, some are not applicable to all patients, some are too complex, and then we just know we're not going to do that in our office on a regular basis, and some just don't have that reproducible reliability. This is the one I tend to use, this nutritional risk screening from 2002. You simply, it's a couple quick questions. You look at their BMI, you look at weight loss within the last 3 months. So have they been losing weight? Have they had less dietary intake in the last several months? Or are they currently in the ICU, which is obviously a malnourished state because they're probably not getting fed? Nutritional impairment, and then is it mild, moderate, or severe? Each of those get a point. And then the severity of the disease process that they're in for hip fractures, major abdominal surgery, head injury, things like that, and then their age. And this just essentially spits out a score for you, and you can look at where they're going to lie on this and what their risk factors are preoperatively. This Duke Pons score actually sums this up really well. And this is just a 3-step process again. Is their BMI, and the BMI is a little bit different, but this just demonstrates another system that what we can use. Is their BMI low? Have they lost more than 4 kilos in the last 3 months without trying? Have they been eating about less than half their food than their normal food in the preceding week? And if any of them are yes, then let's work them up with labs. And although albumin is an acute phase reactant and certainly not a reliable indicator, it still has the best correlation to postoperative outcomes of any marker we can use. So getting an albumin level, a vitamin D level, and then getting them clinically into a clinical nutrition program is important for preoperative screening. And this is the program that they use at Duke. And although we know that albumin is far from perfect indicator of nutritional status, there are several studies. This has been looked at for decades and decades and decades, and still, even currently, serum albumin concentration is a better predictor of surgical outcomes than many other preoperative patient characteristics. And this was a giant study of over 54,000 patients. So we still have to look at this, even though it's imperfect. It still is a nice indicator for us to kind of know what we're getting into. Looking at sarcopenia in the preoperative phase has been gaining a lot of traction in the last probably 10 years. And with the improved technology of CT scanners and the programs that are available to calculate this in real time, and not the laborious way radiologists used to do it, where they had to track everything and get volumes. Looking at paraspinal muscle density and looking at skeletal muscle index is a great way to predict whether we're going to have postoperative problems. And those indicators really signify the patient's nutritional status and specifically their protein status. So if we look at low skeletal muscle index and paraspinal muscle density, those patients with those low numbers have longer length of stay, higher mortality, more infections. It's an independent predictor of mortality, higher rate of blood transfusions, and a higher cost of care. So, you know, me being doing mostly abdominal surgeries, I oftentimes have CAT scans on these patients, and it's a very easy, free program to run those scans through a program that looks for sarcopenia, and you can get these numbers. And these are patients that if it's not an urgent or emergent surgery, I will refer off to clinical nutrition to get beefed up nutritionally before we do their operation. And they really need this prehabilitation, if you will, workup to help get rid of those, because we're really finding, I mean, it's almost inexcusable these days if you have that data to not prehabilitate these patients before they go, hitting them with nutrition, getting them strength training and physical therapy before they go through that big operation. And like I said, this has gained a ton of traction. There are a lot of articles out there on sarcopenia, whether it's oncologic surgery with pancreas, whether it's colorectal surgery, whether it's esophageal, lung, thoracic surgery, but it is just a major cost increase to the healthcare industry and really leads to poor outcomes if we're not taking care of the sarcopenia preoperatively. And so along with this, you know, having kind of a whole plan on how we are prehabbing or pre-optimizing these surgical patients, coming back to that nutrition, it's a big deal. And how long do we have to do it? You know, do we want to really delay our surgeries a month or two? And the bottom line is really 5 to 7 days of preoperative nutrition can make a pretty big difference. This is a great study, prospectively looks at over 1,000 patients that received 7 days of nutrition or they did not. They found about half those patients were at risk for malnutrition. 120 of them had that NRS score greater than 5, putting them at high risk. And when they were treated with 7 days of nutritional supplementation, high protein nutritional supplementation pre-op, they cut their complication rate in half. They decreased their length of stay by 4 days. And they saw this in the highest risk group. Those patients that were fairly low risk or moderate risk with an NAS score of less than 5 really showed no difference. So when you see these cachectic patients, when you see severely obese patients with protein issues, you really can impact this with just a week of therapy. And so we worked with our nutritionist at the hospital to develop a program that really is a plug and play. And we just delay them for 1 week, you know, 1 more week before we board them and make sure things are going well. But it really doesn't delay the surgery all that much. You've probably heard about what type of perioperative nutrition do we want to go through, you know, in immune enhanced formulas or immunomodulated formulas, things like that, and using fish oil and arginine oil supplementation. You know, I have used these and I do use these. They're more expensive. Certainly there is some data out there that shows this. I have not seen a giant difference in my personal practice when we switched to this, but certainly all big companies that make nutritional supplementation have an immuno-enhanced formula. And so that's the one we tend to use. But there are studies out there that show a significant decrease in infection when you do immuno-enhanced over regular, decrease in non-infectious complications, decrease in length of stay. And again, you need that week before to give them this. So we know that we have to supplement a lot of these patients a week with protein supplements. And so we just happen to choose this because there is some data out there that helps with that. But in the long-term mortality outcomes, it doesn't. So we look at this as a cost savings with the length of stay decrease to justify the upfront cost of the more expensive immuno-enhanced. But more importantly, I think, is just getting them going on some sort of protein. If you can't get the immuno-enhanced, it's still high protein supplementation 7 days before is essential. So kind of going back to that Duke pathway, they've spent a lot of time on this, which is nice. You know, after they do that initial score, a malnutrition score and screening, they go through their clinical pathway if they identify people that are high risk. And part of that, just like we talked about already, is the high protein oral nutritional supplementation. They get vitamin D assessment and repletion if it's low, and this is for 3 weeks with the vitamin D supplementation. So it takes a little bit longer to get those vitamin D stores back up. So that's their pathway if they identify people that are high risk. High protein shakes for the week before, and a dose of vitamin D to replete those stores. And so, obviously we're all surgeons. We all want to get our patients to the operating room, and today's world of being judged on our outcomes at such a higher rate than we used to, is it worth delaying the surgery? And honestly, what I saw when I started implementing these is, you obviously have a little bit of a buffer phase where you start delaying people, and you're not so busy for about 3 to 4 weeks, but then everybody's in the queue kind of coming due. And so in the long run, it doesn't change your activity level at all. It just, when you just implement it, just delays a little bit. But essentially, if patients can't meet their caloric needs of at least 25 kilocalories a day, with at least 2 of those being 2 kilocalories per deciliter being from protein, you really should be delaying this and finding a way to supplement them, whether they need a nasoduodenal feeding tube, whether they need a PEG tube, whatever it is to get them that nutrition. And if they're only achieving 75 to 100% of this, then certainly counseling is the first step. Oral supplementation, if they're only at about half of what they really need. And if they're under half of what they need, you need some sort of enteral support to get them back to where you want to do. And you should be delaying any elective surgery, because you're guaranteeing yourself a bad outcome especially if they're down in this phase, where they're only getting about half of the calorie that they need from protein. One of my big pet peeves, and I'm bordering critical care as well, so I spend a lot of my time in the ICU. NPO recommendations and how much we keep patients off of oral intake is really a problem. This data has been out for decades, that we are starving patients, and it's really too bad. And the whole NPO after midnight to get an operation is so antiquated. And I argue with our anesthesiologist constantly about this, that these are the actual recommendations. 8 hours for fatty food of NPO, 6 hours for light, and 2 hours for clears. So there's absolutely no reason that a patient can't carbo load 2 hours before a surgery and still qualify to have that surgery. There is no higher risk for aspiration in patients that follow these guidelines. And so this NPO after midnight, you've essentially depleted your entire glycogen storage, and then you go under a highly stressful catabolic operation for however many hours. And so you're automatically setting that patient up to be malnourished the minute they're in the OR. They're already malnourished because they've been NPO since midnight. So, if there's one thing that we go round and round at that can so easily be improved, is just following the actual recommendations from Anesthesia Society and NPO, and carbo loading these patients 2 hours before surgery. So we have to stop this after midnight, and pediatric surgery has done a great job at this, because kids can't go that long, and they're way too fragile metabolically to go that long without nutrition. And so I think, we really need to follow the guidelines that ASA has come out with, and follow our pediatric surgery and anesthesiologist colleagues on what they've adopted for now well over a decade. So then next in the nutrition phase is really that perioperative phase. We kind of said intraoperatively, I do carbo load all my patients if I can get anesthesia's buy-in 2 hours before. I really try to get them to do all the things in the OR that we not keep the normal thermia, minimize the crystalloid resuscitation to only what they need, things like that, just to keep that nutrition in play as much as possible during the operation. But then we have the perioperative and kind of hospital phase of the nutrition as well. And according to that pathway, and this is what we do as well, we continue that high protein immuno supplementation 5 to 7 days around the time of the operation. This is still that perioperative phase. And so this does match with exactly what we do. So 5 to 7 days pre-op of the immunotherapy, and then carbo loading 2 hours pre-op. Now, this can be a little bit challenging. We all know that a 10 o'clock case doesn't always start at 10. Sometimes a spot opens up and it's 9, but more often that 10 o'clock space becomes 11, 12, 1 o'clock. And so that 2 hour load is a little bit difficult to sometimes time. However, 3 hours, 4 hours is better than since midnight. Okay. So we go based on when our start time is supposed to be, and we go 2 hours before that and do our carbo loading. This can be something as simple as a Gatorade drink, but there are commercially available, high carbohydrate loads, and we'll kind of go over that in a second. So is there any evidence behind this? Yeah, absolutely. So if you look at, this is the guidelines from Surgical Nutritional Summit and the Aspen guidelines. Some very smart people on this society, but looking at the evidence between of perioperative nutrition, and specifically looking at the carbo loading section, this is how we do it: 800 milliliters of a carbo drink 8 hours before surgery, and then another 400 2 to 3 hours before surgery. No evidence of increased aspiration. It complies with the ASA guidelines. You get decreased insulin resistance in the perioperative period, and you get improved retention of lean muscle mass. So essentially, once your glycogen stores in your liver are gone, you start breaking down that lean muscle mass as your catabolic intra-op and peri-op. And so this giving that carbo, giving your body something to work with rather than breaking down lean muscle is really important, and it leads to better outcomes. So this is a really important thing. So kind of summarizing the preoperative nutritional kind of protocols that we follow. Got to start screening people. It doesn't add that much once you get it in kind of in your spiel that you do in your office in your perioperative. Initiate high protein, immuno or non-immuno, but high protein oral supplementation, 5 to 7 days pre-op. Carbo load all patients before surgery. And the protein supplementation is for the at-risk and the malnourished patient population. I don't do this to everybody if they're healthy and don't have a risk factor, but I do carbo load all those patients because they're all undergoing that same stress of surgery. So intraoperatively, I alluded to this a little bit earlier, but certainly for those of us doing gastrointestinal surgery, it should always be in the back of our mind, do you want anesthesia to snake a nasal jejunal feeding tube or nasal duodenal feeding tube down while you're there, and you can feel it and place it in the right spot so you can start early tube feeds post-operatively. If you think that there's going to be an issue with swallowing, an issue with nausea, an issue with something where you don't think you can start oral supplementation, certainly, we need to think about this with any sort of upper GI surgery, esophageal or stomach surgery, placing either permanent access or snaking a temporary access past our anastomosis in order to make sure that we can feed patients early. And by early, I mean, I start when they get to the floor. Looking at judicious IV fluid use, this has been shown over and over to cut down on ileus if we don't flood patients with crystalloids. So keeping our crystalloid resuscitation at a minimum, maintaining normal thermia, which does several things, but certainly cuts down on wound issues. And then glycemic control, and we're going to talk more about this, but keeping it in that 120 to 140 range. And I can slide down a rabbit hole with this, but really we want to make sure that we keep our macrophages functioning appropriately. And we know that when we get above that 140 phase, they really stop functioning to help us fight infection. So post-operative considerations. So we went pre-op, intra-op, and now for post-op. Again, a lot of these patients are going to have some sort of metabolic issue that brought them to your operating room in the first place that we have to consider. Are they on steroids? Are they, do they have cancer? Do they have a big septic load? What's going on? And make sure that we're calculating their nutritional needs appropriately based on these underlying metabolic abnormalities. Looking for gastrointestinal issues, especially those of us who operate on that. Bariatric surgery is very malnourishing procedure. You're bypassing a lot of the bowel. Patients with fistulas, again, patients with dumping syndromes, patients with inflammatory bowel disease, all these things can lead to poor absorption of the nutrition that you're trying to give them. Some of the drugs that we give, things like that. So obviously looking at that whole patient on how it's going to be affected. And, one of the biggest things here is, the NPO until bowel function. The surgeon bias behind how we start refeeding patients is, I'm beginning to think, unbreakable. I mean, the data has been around since the 80s and 90s that it's fine to start feeding people without bowel function. There's tons of papers that show that, bowel sounds have absolutely no indication on return of bowel activity or when you can start refeeding patients. And so it's really, really important that we break this training for our residents that they have to have bowel sounds, they have to have flatus. None of these things are true. And it's really important we get beyond this. And here's again, some Aspen guidelines from Europe, considering that malnutrition is underfeeding are risk factors for postoperative complications. early enteral feeding is especially relevant for any surgical patient at nutritional risk, especially those undergoing upper GI surgery. And, you can read through this. I'm not gonna go through all of it, but getting oral feeding as early as possible after surgery. It's just, I can't harp on this point enough. Here's another guidelines. And honestly, I'm not saying anything revolutionary here. This has been out forever. We just need to follow the guidelines that have been published. But starting with clear liquid diet and advancing one step at a time, there is absolutely no reason for this, and no data showing that it's any better. The clear liquid diet, here's a picture of a tray. There is no good calories here. It's not only insufficient calories, but there's no protein calories in it. And so if you do have to do clear liquids for some reason, you really want to have some sort of clear protein drink involved in this. All the manufacturers make one, but if you're going to do a clear tray, it should have some sort of clear protein drink on it as well, because what's shown here in the picture does absolutely nothing for the patient other than satiate them to have some sort of oral intake. Most of my patients, I start with a regular diet. Any sort of GI anastomosis that's beyond the stomach, whatever you eat, it's going to look the same mid-jejunum, in the colon. It doesn't matter. That's the whole point of breaking this down into a liquid as it passes through. It's all going to look the same. And so I start with a regular diet with high protein supplementation immediately post-op. Again, NG tubes, if anything, they cause more ileus than they prevent. Should only be reserved for people actively vomiting from high-grade mechanical obstructions, to keep them from aspirating. But I really am not a big fan of NG tubes. I almost never use them anymore unless absolutely necessary. The print on this is absolutely, kind of a little bit too tiny to read, but the bottom line is that this is a nice presentation from Penn State about the traditional methods versus the kind of the folklore tradition that we're all taught in residency versus the evidence. And this has been around, like I said, this has been debunked in the 80s, that we have to keep patients NPO, that we have to start with clear liquids, that we have to use NG, that we have to wait for bowel function, that we have to wait for flatus. That's all been debunked in dozens and dozens of studies, but we still don't follow the evidence, and really we need to change. The conclusions are, the NPO until bowel function are not beneficial. Early post-operative feeding showed no negative effects. Early feeding decreased patient mortality and wound dehiscence. Early feeding decreases length of hospital stay, increases patient satisfaction, reduces patient weight loss, and promotes return of bowel function quicker. So, all the reasons that people, hang their hat on saying why I don't feed somebody is actually the exact opposite of feeding someone. So you actually get better recovery, quicker bowel function, and less complications by feeding them early rather than not feeding them early. So it's time to really look into this. Could have made it easier on myself. This slide has it magnified, but the conclusion is we really need to start feeding these patients absolutely as soon as possible. All my patients get, if possible, get fed, immediately, except for those with mechanical bowel obstructions, those that I've left in discontinuity, things like that. Every once in a while, we have to use TPN. It is, meets every definition of poison. So, this should be used sparingly and only for those patients that absolutely have contraindications and cannot get enough calories enterically. It is always a bad thing to do, but sometimes necessary. Higher rates of bacteremia, higher rates of fungemia, higher rates of hyperglycemia, which obviously leads to poor wound healing. Overall length of stay in the hospital increases, non-surgical complication increases, things like that. I reserve it for patients not achieving their caloric goals at 7 to 10 days post-op, or those who are not eating normally preoperatively for an extended period of time. Sometimes they need that early supplementation. But I always continue to try oral feeding at the same time, and stimulate the bowels with whatever medications we need to do that, getting them up walking, all that kind of stuff. And keeping in mind that maybe this is an early small bowel obstruction, and do we need to do some sort of either study or take back to the OR to make sure that we're not missing an early small bowel obstruction versus just a prolonged ileus. So in summary, in the post-operative phase, early feeding and good feeding. So having clears post-op does absolutely nothing. If you have to do clears, make sure you add some sort of clear protein supplementation, avoid extended NPO status, try to get rid of the NG tubes unless we absolutely have to, use the GI tract whenever possible, TPN as a last resort, obviously minimizing narcotics and finding alternative which is a giant topic right now. And there's a lot of alternatives, but using alternatives to narcotics for pain control to decrease that narcotic induced ileus, and ambulate early and often. So that's kind of how we do it. And then we have this other phase. I mean, the patient doesn't really fall out of nutritional risk just because they're going home. And during that convalescent stage, during that rehab, it's very important, again, to maintain that. They're actively healing. They're participating in maybe more activity in rehab than they did preoperatively. And so maintaining that nutritional supplementation in the post-op phase is important as well. And again, this is an example from Duke, but this is how we do it as well. Where I am is we continue in that post-op phase, another 7 days of high protein, and then of the immunotherapy, and then high protein oral supplementation for 3 to 6 weeks post-operatively. So low risk patients, I go about 3 weeks. High risk patients, I go 6 weeks. And along with that 6 week in the high risk patient, clinical nutrition follow-up in the post-operative period, or when they're at rehab. So continuing that through the healing phase to make sure that we avoid post-operative complications are important as well. So kind of pivoting now to talk about some of the other things that I think play along with nutrition and are big warnings that we need to address before we launch into surgery on patients. Blood sugar control and nutrition, they kind of go hand in hand. So I just wanted to take a second to talk about that. 25 million Americans have diabetes, and it's going up every year. 7 million of those, so over a third, are undiagnosed. And so they don't even know they have diabetes or are pre-diabetic. I hear a lot these days. And a quarter of diabetics out there will require some sort of operation. So looking at their glycemic status is incredibly important. The day one blood sugars in the post-operative period are really important to look at. In the higher they are, the higher risk that these patients have for some sort of infection. And so we talk about that kind of 120 to 140 range for perioperative, meaning intraoperative, postoperative blood sugars, in that 120 to 140 range. We did some research when I was in Detroit looking at hypoglycemic effects, and there's still the delirious outcomes from that. So we don't want to go too low, but we certainly going too high above that 150 range, and you're going to start seeing a higher infection rate. So 120 to 140 is really where we want to be. Here's kind of that written out as well. The incidence of surgical site infection in diabetics, those without diabetes, those with hemoglobin A1Cs. So kind of, showing their blood sugar levels over an extended period of time over the last month or so. Those with hemoglobin A1Cs greater than 8 had an 8% infection rate. Those that had good blood sugar control with a hemoglobin A1C of less than 8, 4%. So 50% reduction around here. So my cutoff, there's some other data that I like to look at. My cutoff is 7.3. So I want someone's hemoglobin A1C less than 7.3 before I do an elective case on them. The graph really starts to uptick after about 7.3. So that's my cutoff. Post-op infections are increased by 30% by every 40 points over 110 for your blood sugar. So this is important, so that's why that 120 to 140 range. Once you get to 150, 30% increase. Once you get to 210, 30% more increase. So we really have to keep those blood sugars under control and address that. And if you don't want to do it, make sure medicine's involved, someone's involved to make sure that's taken care of. And the big things, and I mentioned this a little bit earlier, but we need those in order to decrease infections. We need our macrophages and neutrophils to function. And the minute that blood sugar is over about 140, you get chemotaxis and oxidative bursts of your macrophages. You get phagocytosis. They're just not functioning to help you fight that infection. So, if you've ever been able to hear Bob Martindale talk on this stuff, he's an absolute genius and guru when it comes to this. But the bottom line is we need that neutrophil and macrophage function. So the perioperative glucose recommendations, I kind of already mentioned this, but so preoperatively 30 to 60 days, so 1 to 2 months preoperatively, get those hemoglobin A1Cs at least less than 8, preferably for me, like I said, less than 7.3 is my cutoff. For the high risk patients, bariatric vascular, abdominal wall reconstruction, obese, if you have to have them see an endocrinologist to get that under control, you should do it preoperatively. This is a big thing you can do. You're not doing any extra work on your own, but get someone to manage this for you to really cut down on your postoperative risk. And then immediately post-op and perioperative, target that 120 to 140. But in all honesty, kind of 140 to 180 is okay. So if you have a hard to control diabetic, if you can keep them kind of in that 140 range, you're okay. But the sweet spot is really that 120 to 140. But really above 180, 200 is where we really start to see the friggin' logarithmic rise of complications. Obesity, and none of us are getting away without operating on obese patients these days. This is from 2014. It's up again. I think we're down to we're about 30% of patients are not obese or overweight. So we're over 2/3 of the American population is either obese or overweight at this point. So we really have to take a look at that in the preoperative phase. And again, if they're not emergent, getting them to undergo some sort of medical weight loss. And if they're morbidly obese, maybe surgical weight loss consultation before an elective surgery is important. This is a big meta-analysis looking at 13 studies, all supported a relationship between obesity and surgical site infection. I mean, it makes sense. Like the bigger that sub-Q space is, the more it's going to get infected. So getting someone to lose weight preoperatively is really essential. And everybody always asks me, well, what's your magic number? Is it a BMI of 40? Is it BMI of 45? Is it BMI of 30? The bottom line is whatever it is, the smaller the BMI, the better. Okay. And not to go into malnutrition state, obviously, but BMI is incrementally associated with wound complications. So a BMI of 39 is better than a BMI of 41. So if you can get someone to even lose 10 or 15 pounds, honestly, it will be reflected in your surgical site infection incidence. So please, this is, delaying a little bit to get someone to lose some weight is really important. Using medical or surgical weight loss to delay elective surgery. And again, another study showing this: being overweight or obese substantially increases the likelihood of patients developing surgical site infections. So again, looking at potentially doing a weight loss, either counseling, medical weight loss program, or a surgical weight loss program can really help you get your surgical site incidence down. Smoking should go without saying. Many countries, Great Britain, and even some states, Oregon now, you cannot electively board a hernia case if the patient is actively smoking, if they're a Medicare or Medicaid patient. But this goes back to, to almost 20 years now. But Sorensen and Lindstrom, huge reduction of wound complications if you got patients to stop smoking. So about a 50% reduction in wound infection in the Lindstrom data, and 6-fold in reduction from the Sorensen data. So massive reduction. And one cigarette, the amount of vasoconstriction one cigarette causes leads to all these problems. And you really need that blood supply to the soft tissue in order to avoid surgical site infections. Nicotine supplementation is probably okay, but some people are anti that as well. In certain populations where I work, the smoking rate is so high that if I didn't use nicotine, I wouldn't, really have a lot of operations to do. But it's probably okay. The sweet spot is about 4 weeks. So getting someone to stop for 4 weeks essentially puts them at about the same risk as someone who's a non-smoker. Once you go more than 4 weeks, there is some data that people develop a cough, and so you're getting a mechanical stress on your wound, which can lead to then higher wound rates. So kind of that 4-week mark is important. But if they want to quit earlier, I do not stop them. But we are getting to the point where we're testing nicotine levels preoperatively and canceling elective surgeries if they're still actively smoking, especially hernia surgery, big abdominal hernia surgery. Marijuana, e-cigarettes, vaping. Vaping obviously has a lot of pulmonary effects, and so we want them to stop that if possible. E-cigarettes, again, if it's the nicotine, we don't really know and have a lot of great data on that yet. And then marijuana, we don't really know. But now with states legalizing this, there's going to be some better data coming out soon, I think, on whether that's an allowable thing or not. Antiseptic showers, there's a lot of data out there. Some say it helps, some say it doesn't. The bottom line, the newest difference, this is a little bit older slide, but newer data, I think out of Cleveland, stated that probably 24 hours before with Hibiclens wipes is the best way to do it. The 3 to 5 days of Hibiclens showers with all the detergent was causing a change in the patient's skin biome and was leading to a higher infection. So probably just some MRSA wipes, some Hibiclens wipes to get the MRSA off the skin the night before is probably where we're going to end up landing on this. Staff clearance. We used to use mupirocin for 5 days before. Now there's a 3M product that clears it with 1 dose. There's the big New England Journal study that shows it's better just to treat everyone than to universally decolonize everyone rather than do testing. So this is one we do as well for MRSA. The rates are obviously huge. And, this is one of those, we got to be careful which studies we look at. There are countries that have a MRSA rate that's, in single digits. Obviously the US is not one of those. And so we got to make sure we're comparing apples to apples when we look at treatments for this, but decolonizing with the new 1 dose is what we're doing now. Hair removal, clipping rather than shaving. This has been around a long time, but avoiding any nicks in the skin. That's where we're seeing a lot more surgical site infections. And then antibiotics, following the appropriate guidelines released by the CDC based on what you're doing. And the thing is making sure they're weight-based. We always used to do 1 gram of whatever cephalosporin we wanted to use. And now most patients are 2 grams and the obese are really 3 grams. And we want to make sure we're dosing as close to that incision as possible, redosing at 1 to 2 half-lives for the drug, depending on what drug it is. And if you have a large volume blood loss greater than 1,500 milliliters, you want to redose as well because you've diluted that presence of that antibiotic in the blood. Really no need to keep those antibiotics going more than 24 hours for purely prophylaxis. I do not dose after the OR. There's pretty good data out there on that. I just simply dose in my before incision. I redose if I have to because it's a long case or I have blood loss. And there's no need to treat post-operatively. No need to treat just because you have drains in. That data is very clear. Again, from my ICU days, I want to avoid C. diff situations. And so I'm pretty strict on my antibiotic stewardship. Skin prep, looking at what causes better outcomes. DuraPrep tends to be pretty low, but picking your protocol in your hospital and making sure that you're picking a skin prep that really does a good job is important, again, to avoid these. And then, another topic that's kind of near and dear to my heart is incisional negative pressure. I published a paper on this back in 2014 now, but looking at decreasing wound issues when we use negative pressure. And there's a nice product out there and it really relieves that tension on the skin. It sucks the hematoma or seroma from underneath the incision until that space closes down, or the epidermis seals. And it really acts like a localized binder to keep that wound from pulling apart. And it's a sterile dressing that's placed in the OR, so you keep it on and it avoids contamination of that skin. There are dozens and dozens of other things, from OR hats to how we scrub to beard masks and things like this. So really, we want to make sure we're doing everything we can. But the big ones, I think, are what we have covered here. And obviously technique as well. Avoiding dead space where seromas, hematomas can form and then become abscesses. Avoiding excessive foreign body. These are, Halstedian rules from, hundreds of years ago. Minimize dissection. Getting good hemostasis, handling the tissue carefully, not crushing it, avoiding tension, aseptic techniques, things like that. So we've really kind of covered all of these areas from nutrition, as well as a couple other caveats that I think lead to very low surgical site infection. The big ones that I really wanted to touch on today were nutrition, obviously the focus of the lecture, blood sugar control, both pre, intra, and perioperative, smoking cessation, weight loss. And those are the big ones that we can make a giant impact with very minimal input from as far as effort goes in getting patients ready and minimizing our surgical site infections. So at this point, this concludes the lecture. We're happy to open it up to any questions that we have at this point. Thank you very much. Hello, welcome to the Q&A portion of today. My name is Dr. Casey Thomas, and I look forward to answering some questions based on the talk I gave. We've got quite a few minutes here, and we'll start with some questions that have come in already, and it'll give you guys time to type in some other ones into the chat box and we can answer those. But before I get to those, a question that often comes up is, and more from I think the surgical side of things, the surgeon side, the physician side, is where do I even start when I want to do a pre-optimization type program. It seems daunting when you start looking at, weight loss and smoking cessation and nutrition and physical activity and all these kinds of things. And I think the answer is just start taking small steps. Obviously smoking cessation is a big one. It's fairly easy to do. And it's going to, at some point, just become the requirement that we can't do elective surgery on people who are actively smoking. But it's already kind of happened in some places. So I think that one's an easy one. Nutrition is one where doing a quick questionnaire and getting things going. And most nutritionists in the hospital they have the personalities of people who really want to work with anyone who wants to help use their skills and get patients better outcomes. So those, I think, are the first kind of two places to start. And then you can start working with your medical and surgical weight loss teams. And before you know it, you've got protocols all designed for this. And you can also approach your hospital about investing in a nurse or an advanced practice provider that's willing to kind of spearhead this and open up your own kind of clinic to do it. So I think that's a really nice way to start with this. But let's get to some of the questions that have already come in. Do I have concerns with protein supplementation in the presence of kidney disease, stage 3 or 4? Of course, it has to be on your radar. I think there's several, quite a few good studies out there looking at the difference between protein supplementation and protein breakdown and renal clearance. And just because someone's, creatinine necessarily bumps doesn't necessarily mean that we're having, increased renal damage. But in these situations with severe kidney disease or dialysis patients, this should obviously run by their nephrologist before we just go and implement a plan. But I do you still use protein supplementation in patients with renal disease, but we always make sure we have the blessing of their internist or nephrologist before going full bore. Early renal insufficiency or people obviously without, then yeah, no problem at all. So. Do I look at pre-albumin as determination of malnutrition? Not usually. Sometimes it's just in the lab bundle that was obtained by someone and it's there. And of course, I'll look at it if it's there. But we know that pre-albumin and albumin are acute phase reactants. They're not necessarily indicative of real nutritional status. However, they correlate very well with outcomes. And so I'm really not looking at it as a determination of malnutrition as much as a determination that I might need to look deeper into someone with that has malnutrition, go down the questionnaire. And because we're pretty much supplementing everyone these days, that's going to get a big surgery, it's not as big a deal as I think as it used to be. But certainly if it's on the labs, I look at it. But no, I do use albumin more than pre-albumin, and I weight the questionnaire and recent weight loss, BMI, looking at their diet, things like that more. But the albumin, obviously, if it's low, down in less than 2, that's a big trigger for me to dig deeper into that. I don't use anything really as a one-off marker for anything. It's a supplement, and it's albumin. And if pre-albumin is there, certainly, and the questionnaire and their diet, it's everything. It's not one magic thing. What are my thoughts on implementing Ensure in your preoperative nutritional planning? We are recently started incorporating this alignment with our anesthesia group. Absolutely. I mean, you can, a lot of us don't have a choice on a brand or a specific type. And I think something is always better than nothing. And so if Ensure is your product of choice, that's fine. Some sort of protein supplementation. If you can make that an immunoprotein supplementation, great. If you can make that an immunoprotein supplementation with fish oil, great. But anything is better than what we're doing right now, which is nothing. So kudos to you for already getting this in and incorporating your anesthesia group. Sometimes that's the biggest hurdle on this pre-optimization. Using fish oils preoperatively because of their anticoagulation nature. Yes, you're absolutely right. Fish oils do have a natural anticoagulation tendency. I have never seen an issue with it. If I have someone who has a coagulation risk already, thrombocytopenia, some sort of coagulopathy that they come with, I might think twice about it. But in general, no, I don't really worry about it for its blood thinning property, and certainly it's nowhere near the Xarelto, warfarin, Eliquis type anticoagulation. And so, yeah. Immunomodulating supplements, do I recommend who present with fish oil? I use Impact because it's what we have at our hospital. I don't really get a choice. When I was at a different hospital, we used something else. I can't remember, maybe a Nestle product. I can't remember what it was, but whatever's on the shelf. And again, reiterating, something is better than nothing. If you can't get immunomodulating, just do high protein. If you can't get fish oil, just do immunomodulating. Whatever you can do is best. But most brands make some sort of combo, and I think it's the presence. It's repleting that arginine supply. It's getting the anti-inflammatory effect of the fish oil. So the more you can do, the better. But the biggest hit, in my opinion, comes from increasing the protein load. Really getting these people, getting their lean muscle mass up. So. How do I actually conduct pre-op enteral nutrition program? Yeah, so that's in the presentation. So 7 days pre-op, 7 days post-op if they're medium to low risk, and then I'll do 14 days post-op if they're higher risk, plus a nutrition consult for follow-up on that to avoid them slipping back. But yeah, minimum of 7 days pre-op. Now, if I find someone with severe protein calorie malnutrition that is cachectic and all that, then they go for a full nutritional eval before. But those people that are moderate or slight or fall in those, whichever scale you want to use, fall in kind of those moderate to high risk, but don't need enteral feeding, don't need an NG tube or a Dopoff tube or a G tube or a J tube to replete their protein supplies. Those people get 7 days pre-op. Hospital coders use albumin to measure protein calorie malnutrition, mild, moderate, severe. Is pre-albumin being used now? No, and it's a poor the disconnect between what we do, the diagnosis, and the coding. This is the game we play in medicine these days. We need to make sure we document and order the labs to support our diagnoses. It doesn't mean that's the diagnosis, right? I mean, this is coding, billing, insurance payment is completely separate than clinical medicine, and they should not be looked at as the same. We want to be good stewards of that. We want to make sure that we can keep the lights on at the hospital and that we document efficiently and correctly, but those things don't overlap. They're completely separate things. When I started medicine 20 years ago, the chart, the documentation was to provide clinical information to other members of the team. Now it's purely a billing issue, so the EMR has almost nothing to do with actual patient care. So just be very careful with that. I wouldn't, just because a coder says you need it to diagnose malnutrition, that's not true at all. We all know that as clinicians. So make sure that we're doing it based on our diagnosis, not what needs to be sent to an insurance company. How do you dose Zosyn Q8 given over 4 hours? That Zosyn, I mean, unless there's a specific bug you have grown out, Zosyn should not be a perioperative prophylactic antibiotic. That's a pretty heavy gun for that, unless you have culture proven evidence that that's what you need to use. And the MICs based on your cultures and the half-life of any antibiotic is where your redosing comes from. So I'm not going to get into the weeds on that one. The pressure dressing I use to apply to incisions is called Prevena. It's a product by KCI. And just for full disclosure, I am a medical advisor for that company, but I wrote a paper on that, and back in 2014 it was published in Hernia, if you want to look at those results. And there's also, hundreds of articles now showing better surgical site infection outcomes with using Prevena. Pre-albumin, pre-op, no. A lot of pre-albumin questions. No, I don't care. I mean, if we have gone through all the steps we need to do, it doesn't matter, right? And so if I'm operating on someone for an acute issue, it's going to be up because of the inflammatory response. So no, I don't hang my hat on labs. I just use it to as a supplement to all the other information I've gathered. So, doesn't pre-op nutrition repletion in hospital eat up DRG? I guess I'm not sure I quite understand that. So you're pre-optimizing someone who's already an inpatient. What I'm speaking of is someone comes into your office, you're trying to get them going for elective surgery and getting them pre-optimized. Any inpatient should just be going by your nutritional protocol, which should be feed as early as possible. Don't rely on bowel sounds. Don't rely on bowel movement or flatus. Don't worry about an anastomosis, unless it's esophageal, and just feed these people. That evidence has been out since the 80s. So I'm not quite sure what this question means, but no, I'm not doing any pre-optimization in hospital. They're just on their regular nutrition protocol. Recommendations for pregnant women. I don't operate on pregnant women unless they're shot or they have a hernia that needs to be fixed at the time of their delivery. So that would be up to the OBGYNs. But if they are undergoing an elective surgery during pregnancy, which I'm not sure what that would be off the top of my head, but they should be pre-optimized as well. I mean, nothing in here is going to hurt someone who's pregnant, just good nutrition, essentially, carbo loads. Yeah, I've noticed admission albumin maybe 3-4 and 2 days later it's 2-4. Yeah, how to interpret this? It's hemodilution. You're absolutely right on your second part of this question. So if it's 3.4 and I give someone a liter of saline and measure it right then, it's going to be much lower. So this is why everyone talks about it being such a poor marker of actual nutritional status. It's way too dependent on everything else. And so this is why when you say, do I get prealbumin in the hospital pre-op? No, I don't know what it means. You could tell me it's whatever number, pick a number. But if it's higher than it was 2 days ago, or if it's lower than it was a day from now, I don't know what that means. So I think it's a waste of money to get, albumins and prealbumins in hospitalized patients that are receiving other therapies. It doesn't make any sense. So if I get a pre-op albumin and it's 2.5, and I say, okay, well, I know that at that rate, this correlates with better outcomes. That's really all I'm gleaning from that information. I will still put them down the pathway. But when they're in the hospital, then if it comes back, after their surgery at 1.5 and they've gotten a couple liters of fluid, it doesn't mean anything. Like don't let anybody tell you it does, because it just doesn't mean anything. So, and this is why, circling back to that coder question, the billers and coders should be coding protein, calorie, malnutrition based on what you put in your assessment as a clinician. So, you can document that and say, caloric intake less than 20% of ideal, patients demonstrating signs of muscle wasting and cachexia. And that's protein, calorie, malnutrition. Now, if you need a lab to define that for an insurance company, that's fine, but it's erroneous. I mean, they don't understand nutrition then, because, that an inpatient albumin means nothing. I mean, especially without ability to at least trend it, so especially if they've got an inflammatory response going on, especially if they've gotten resuscitated or they're hemoconcentrated. So, I think that, unfortunately, this is one of those things that someone told an insurance company that you need this to prove it or otherwise we won't pay. And so now we all have to pay to get a lab we don't need. And that means absolutely nothing. So, so if there are other questions, please type those in. We got about 4 more minutes here. I'm going to talk a little bit more about a couple of questions that come up. Oh, here we go. This is another one. I was referring to the Duke program, which seems to imply pre-op. Yeah, I believe they're meaning outpatient pre-op, not inpatient pre-op. Now, there are certain things you can do if someone comes in and you want to optimize them. They come in partially obstructed with a colon mass, and you want to tee them up for surgery, certainly, and they're going to be sitting there for a day or two, certainly optimizing their nutrition pre-op, but it's going to be dependent on how many days they're going to be there before. But certainly the carbo loading, the post-op ERAS protocols, things like that should always be in place for that. Yeah. That's, I think, the most important. But yeah, most of the stuff I was referring to is outpatient, but certainly we want to tee up patients as much as possible if we have time in the hospital. And those protocols should be in place with enteral feeds if they can't take oral high protein, if they can take orals, and getting them ready for surgery. So I've gotten the okay that we can end this. So if there's no other questions, thank you all for participating in this event. Hopefully it was beneficial to everyone, and I appreciate the opportunity to speak with you guys. Thank you.